Assalamu alaikum and welcome back to Medicower. I'm your host Rubina Mia, and today's topic is about hospice care and the care of people who need palliative or end-of-life care. My guest today is Amy Dunnell, who's a lead educator who works with Sue Ryder Hospice, and we've been covering lots of things about what hospice care involves and how people might use the services, and we're just about to move on to other areas about how we can support the more specific communities, such as the Muslim community. I come from a faith community. How much can a hospice support my religious needs?
As we've discussed, we're very much about providing person-centred care. So we meet each individual and their loved ones, carers, with an assessment. What matters to you? What do you need? How might you want to be cared for at the end of your life? Where do you want to be? Who do you want around you? So we would tailor whatever we did to meet those needs. And if you had very specific needs, for example, needing to have a space to pray or having particular people with you, we would make sure we went out of our way to support that.
I noticed when I came into Sue Ryder today, actually, that behind the reception desk you've got a quiet room. Is that one of the places where you direct people to pray who are visiting? Yeah. Yes,
so we have a non-denominational room. Yeah. So we are here to support people of all faiths and spiritual beliefs. We don't support anyone more than another. So our quiet room is non-denominational. You can come and spend time in there as a patient, a family member, request time. We only have that one space, but we would do our utmost to support you to be able to use that.
That's always lovely to hear, because a lot of the time it's not about that space is available, it's about the attitude towards helping you find a space.
Yes.
And that's what's really refreshing to hear a lot of the time, yeah.
And we spoke about having most people have a private room, and that we would enable people. Sometimes people bring in personal possessions, things that are very important to them. We've had people bring pictures in, we've had people bring their pets in.
All right, okay.
Perhaps not to stay permanently, but to be able to connect with what's important to them.
I don't think you can do that in a hospital, can you? Take your pet in?
Probably not. I think it would depend on the size of the pet.
Yeah.
But it would, we would do our very best to enable you to have the most important things and the things that matter to you the most. And if that is around your faith and around your spiritual needs being met, we would go out of our way to support that.
I mean, in our faith community, visiting the sick is a really important part of our faith practice, and sometimes that can be quite daunting, particularly for the hospital staff who want to control 2 people around the bed. You know, we understand and appreciate that does have to happen for the patient to get rest. And at the same time, you know, we're always good. I think lots of us in our families are good at sort of saying, okay, if you're going at that time, I'll go at that time, or we'll wait to give each other turns. Yeah. So, but lots of visitors often visit within the Muslim community, and I wondered how you coped with that.
Well, we have an open visiting policy. There are no restrictions on hours or numbers. We would work with you and with the patients. We sometimes find people, as they're approaching the end of life, can be more tired and may be less able to engage with people or larger numbers of people. But we would work with them and with you and to support everybody, as I was saying before, to balance everybody's needs, because as family members you have needs there to connect with your loved one. And
some people travel to visit the relatives that are ill because they don't know if they're going to be able to see them outside of those time frames, or they might miss them whilst they're alive. But I think one of the biggest advantages you're talking to me about is the fact you've got an open time frame for visiting, and I think that absolutely would change some of the numbers being there in large blocks at the time. So that sounds to me like it's a really healthy and productive way to control visiting and coming in large numbers as well.
We really want you to be able to spend the time that you need with your family member. So we would work with you, and I would have open and honest communication about how that might work.
Sure.
And we absolutely would embrace and support you to be with your family member.
Thank you, that's really useful to know.
And I'm saying we've just recently we recognise how important it is to have families and friends and loved ones present. So we've just recently we're just improving a family space at the moment that we didn't have before. So we've just moved around things and been incredibly lucky to have donations made to be able to provide that space.
That sounds really good.
Yes, and so we're hoping to create another space very soon also. So yeah, and we have camp beds and spaces where people can sleep, you know, in the short term, so that they can be as close as possible.
That sounds like a really lovely setup that you have there. And obviously at times like this you kind of hope those are the things that are going to be made easy for you, don't you?
Yeah.
I guess what I'm also wondering about, Amy, is your staff and their ability to relate to patients who come from other faith groups. How are they trained, or how are they sensitive to the diversity of people that might use a hospice?
All of our staff receive mandatory equality and diversity training, and that's part of their induction. We also have a strong emphasis on person-centeredness and personalisation, or you know, providing person-centred care. So it's absolutely fundamental that we connect with each individual person and what's important to them, what their practices are, what their faith might be, what their social needs or psychological needs are. So I would say it's very much encompassed in that.
So it's not about them being experts in every faith community, it's about the fact that they know how to show respect and support what is important to that family and that patient themselves.
Yes, and we have at Sue Ryder, and I'm sure most of many other hospices, we have a very clear values and behaviour framework that we expect all staff to work within, and that's very much encompasses this person-centred, individual approach. So we can't be experts in everybody's faith.
But it's the attitude, isn't it, by which you engage with people.
It is, and we approach each person openly, and we want to work, come alongside each person and plan the care with them, support them, make sure they have what they need. So that's very much embedded within our values and behaviour framework. There may be more we could do. That we talked a little bit, didn't we, earlier, about perhaps could we do more training? Do we need to? And that might be something that we want to look at.
Yeah, and I don't make this specific to Sue Ryder, but I think certainly in my work that I've done around bereavement, there are masses of gaps in how the diverse communities and faith groups' needs are being met. And I think there's lots more that could be done in most agencies, not just in Leeds, but in other cities where we need to be more inclusive. And I think that's one of the things that I'm certainly passionate about, working with others to build on. And it's about being open to acknowledging that you've got gaps so that you can build on it, rather than thinking that, no, you have to fit into our model, and that's what makes it hard for people who come from different backgrounds and sort of practices.
And in another role that I undertake is we work across Leeds, so we have a managed clinical network for palliative end of life care, and on that we have St Gemma's Hospice and Sue Ryder Wheatfield's Leeds Community Health Care, Adult Social Care, Leeds and York Partnership, Mental Health Trust. Trying to think who else we've got. We've got a large number of partner organisations, and we're working together to look at palliative and end-of-life care in a more strategic way. And actually one of the areas might be that we want to look at how we engage with diversity and different faith backgrounds, and is there anything that we need to do and change that in a more strategic way?
I would certainly hope so, because I think from the point of view that I'm coming from is there is an absolute need for this, and I think it isn't because we can't be treated with kindness and compassion, but it's about the ability to not have to put more energy and time into having to explain to somebody why they need when you're already worrying about everything else that's going on. I can think of times when we've looked at counselling services and you spend, people have said to me that you spend your whole session having to explain your religion and culture to somebody, so you don't get to develop and benefit from the counselling, because your whole session is about having to train that person on something that you want them to have understood already, or to at least understand how to work with already. It's another debate for another day, I think. But thank you for sharing that. We talked about earlier before the break, we talked about this advanced care plan. What's that all about?
So we were talking about why you might want to when you might need a hospice, or why you might choose that. And actually, I think before that, we need to think about thinking about our own death or our own family member. What might I want? Where might you want to be? Who do I want around me? And that's essentially what an advanced care plan is. It's about setting out your wishes and your needs, things that are really important to you.
It sounds like the opposite end to the birth plan that mums go through.
Absolutely.
Is it the same kind of thought process, but for death?
Yes.
Yeah.
So it's about setting out an intention. There may be things that are really important to you, things that you don't want to happen, things that you do want to happen. Now this is different to an advanced directive, which is a legal document that states very clearly things that you don't want. Okay. And
how does that vary then? What can people put in a directive?
An advanced directive is very, very specific, and you do need legal support in making what it might be. You may have a desire not to have a blood transfusion, for example.
I understand. Right. Okay.
And you'd have to set out very clearly in which circumstances you didn't want a blood transfusion, for example. Or it may be that you don't want to be ventilated or tube fed. So
they would need a legal document to say the staff have to follow that. That's what it is. It's a directive.
So if we put that to one side, what an advanced care plan is a much broader, and I would say more of an intention, very much like a birth plan. These are the things that are important to me. These are the people I want around me. This is where I might like to be, but acknowledging that we can't always know what the future holds.
Of course, and it's the wish list, isn't it?
It's a wish list, exactly. Yeah. And we really strongly encourage people to think about that. Even now, start having conversations much earlier on with our family members, and it enables then an open dialogue about death and dying, so that it becomes
easier said than done, though, isn't it? Having that conversation. I know I've many times tried to have conversations with my young adult children about, preparing them for how to cope with that if I'm, going to die, and the barriers that you get for being able to talk about that. In my faith, we talk about death in lots of contexts. We don't shy away from the topic a lot of the time, but I think when it comes to the nitty-gritty of talking to your family members, I know I've made sort of statements to my family about, I want you to know about this, I want you to know about that, but I know when I've tried to have that one-to-one conversation with my own children, it's been certainly when they were younger, they're more open to it now, but certainly when they were younger, and I don't mean too young, I meant when they were young adults still, it was hard for them to have that conversation. Yes. So how do we move that post forward? How do we take steps in the right direction with that? You got any tips for us on that?
I think it's a really interesting conversation, and some of us call it the big conversation. And actually, I think it's embedded within our culture and society that this is something that we find tricky to talk about.
Is it easier because you've got a terminal illness to have that conversation, do you think?
I think it varies. I think it depends on you as an individual. Some people find it easier than others, and it might depend on their beliefs, faiths, spiritual beliefs.
I think it's often to do with the fact that the coping strategies is, it's the denial, the ostrich syndrome, if I don't talk about it, it's not going to happen kind of thing. I think that's particularly with young people.
Yeah. It's perhaps something that we don't want to think about. And, it's very individual. It depends on, your family, as you say, and what kind of coping strategies we've got.
I think my daughter went through a phase where she thought if I talk about it, it just makes it come quicker than it should do, and I think that was one of the reasons why she didn't want to talk about it. And actually then we got to a place where we needed to talk about it, and then but I found more creative ways to talk about it, I have to say. But I know there's lots more that could be discussed.
In Leeds, we have the Dying Matters campaign, and this is a health promotion. This is very much about engaging with the whole community about how do we open up these conversations? How do we enable it?
I think it's harder in the non-Asian community than certainly within the English colleagues and friends that I've got. It's a subject that's very hard to talk about.
And that's why I think starting to have some of these conversations and to be invited here is an opportunity for us to start just reminding people that we do need to think sometimes, we do need to think about where we might want to be, how we might want to be cared for, and what's important. And we can write that down, and we might not, it would be ideal to discuss it with your family members, but you can just write that down. It's not a legal document, it doesn't need to be seen or signed, and have that held somewhere, you know, perhaps somewhere where somebody could get to it if you weren't able to make decisions for yourself. And I think this is not a one-off conversation, it's an ongoing.
Yes, I think you're absolutely right about that, because I think that's what I've been trying to sow those seeds, and they start to germinate gradually. You know, it's not something you should, I certainly think for me and my children, it's been important to not make it a sledgehammer moment, but rather a gentle conversation and a sort of, you know, I needed to think about this, but you know, we're not going to talk about it all now.
Yeah, and I guess acknowledging that sometimes having a conversation about death and dying can feel frightening, or acknowledging how that might feel for somebody. How does that feel, and what are our fears? Because that enables more of a dialogue.
But like our taxis, death is going to come, isn't it? We can't avoid it, can we?
That's right.
So I guess it's about how we make the best of it, and I guess for some people it is about planning, but for others less so, because of their different circumstances. And even when you plan something, it doesn't necessarily mean it's going to happen like that. Right. But at least being able to share your hopes and wishes for that would be healthy, wouldn't it?
Yes. And our community team and our district nursing colleagues will start, if you do have contact with them, may ask you about, you know, this, you know, what is it, where do you want to be, what's important to you, what kind of care, what kind of specific practices might be important to you, and we will ask those questions. And it's because we want to make sure that we've captured what's important to you.
And I guess they're not written in stone either. I'm sure you could adapt to them and change them.
Absolutely.
I guess the worry is, I'm thinking about if I wrote an advanced care plan, and up until a certain point of being unwell, and that I'd think, okay, they know my wishes. But then if you became into a state of unconsciousness and you know, you wouldn't necessarily be able to adapt to anything, but then your family members might know that under certain circumstances you might want things to change.
And that's when it comes into play, when you may not be able to communicate your own needs and wishes or make a decision yourself. And we can use that then to guide the care, to make sure we act in your very best interests.
And it is a guidance, isn't it?
It's guidance, it's not written in stone, it can be changed. And we talk very much about it being an ongoing conversation, because you might change your needs, and we talked earlier, didn't we, about balancing patient and family needs, and these shift and change as we face different challenges.
So what kind of topics come under the care plan?
It's very much guided by you.
Okay, so it's not got headings or anything, it's just a case of, all right, okay.
And some people might want to think about what's really important after I die. Are there people that I want contacting? Are there is there a particular practice required about how you want to care for my body? Do you have specific needs around how you want to be buried, cremated, who you want at your funeral, who you don't, what music? You know, it can be as broad or as short as you want. So
it's so specific that it's that individual.
It's very individual.
So what about issues around pain relief and you know, when somebody's in those stages of dying, what do families need to understand about those stages of dying? What might they need to prepare themselves to expect?
I think that's a really interesting question, and it's challenging to answer because it's going to be difficult for each person.
I guess this is the bit that we all worry about and don't talk about, and I'm trying to sort of make that easy for us to be able to open that dialogue, really, because I think when I'm sitting here thinking about that issue, I've never been with somebody except in a professional capacity. So and even though I've been around family that have died, I've never been through anybody that's been through a hospice system or through that long-term illness. And I'm thinking, well, how would I prepare myself? What should I expect to happen so that I can be prepared to say, okay, this is normal for this stage of dying? Is that something you can talk about?
I could talk a little bit about it. I think it's very individual. It might depend on the condition that you are presenting with. Thinking about approaching death, we might notice that people are a bit more withdrawn, so may withdraw somewhat from conversation, from previous activities.
Is that because of weakness or because of something else?
I don't know the answer to that. My guess is that it's probably a bit of both.
Okay.
So we may have our physical capabilities will reduce, and so therefore being able to engage in activities that we did do previously will not be possible. But there's something about almost a social withdrawal, and I don't know whether that is to do with energy levels.
Because it's common to hear people stop eating and drinking regularly.
That's right. And so as we're approaching the end of our lives, we appear to be less hungry, less thirsty, and to have much lower energy requirements. Appetite can diminish, and people might sleep for much longer.
So sleeping is not just to do with medication and pain relief?
No.
Okay, I didn't think I knew that.
So you could be sleep for longer. You may be on some medications if you have symptoms, and not everybody does have specific symptoms at the end of life. Again, very dependent on the condition that you have. So if you did have some pain, we may give pain relief, or if you did feel sick or have nausea, we might give some medication for that. But that's very variable and dependent on the individual.
Okay. So how do you support a person who's in those very last stages? You know it's imminent that they're not going to be with you for very much longer.
We provide care to enable the person to be as comfortable as possible with privacy and dignity, and support the natural process. You know, we might reposition people because you would tend to be in bed, so we would support repositioning to make sure that the skin remained intact, keep people's mouth hydrated or moist, make sure that the people who need to visit or want to visit can be there, so there's some psychological and social support there. But working with each patient, it may be that you need medication to manage some symptoms, and we sometimes give that through a device called a syringe driver if you can no longer take the medicines by mouth. So that would be part of the care, and assessing on a very frequent basis, you know, how you're feeling, what your comfort levels are like.
I think that's the worry, isn't it, from a family perspective, is, you know, how uncomfortable is your loved one, how much pain are they in, is this normal when they're having other, you know, when there's noises coming out from them, you know, is that normal?
Yes, I think it can be. Sometimes we can have secretions that collect in the upper airways that can cause some noise, and that is normal. And we sometimes give medication to reduce some of the secretions, but that is part of the process. And
will pain relief for somebody in those very last stages of life who needs pain relief always make them more unconscious, or not necessarily? Not
necessarily. I think people are very individual and respond to medications in different ways. People can feel some drowsiness, but not everybody does. And we do provide other so we call it non-pharmacological, so non-medication support. So perhaps if somebody was breathless or feeling anxious, we have complementary therapists at the hospice. And I was saying about our occupational therapists who are able to provide some support with without medication to help you to manage your breathlessness if you had that. And our complementary therapists, we're incredibly lucky to be able to provide complementary therapy, so aromatherapy, massage, Reiki within the hospice that may help with your comfort. Again, we're so blessed to have that service.
And if somebody's bedbound for a long time but too weak to get into a bath or a shower, how is that sustained then, that level of hygiene and cleanliness? Is it just bed bathing?
It could be, yeah. I mean, at the hospice we have bathing facilities to enable people who are less mobile to get in and out, and a hoist. But it could be, yes, personal care at the bedside or in the bed.
And then at the time of death, when somebody's literally just died, I think, you know, we're going to have to speed this up just because the time's gone so fast, but yet maybe I should leave that question for another time, actually. I really want to talk about, before we do finish, is that we've got how would the community get the best out of a hospice? How would we work to get the best for ourselves and our families with you?
I think being open and honest about what your needs are, and not afraid to tell us. You know, this is what's really important to us. This is what we really need, so that we can then work with you to provide that. That would be my top tip. And I think about speaking about your wishes with your family, making sure that you've perhaps got that down on a piece of paper somewhere, or you've had that conversation with your nearest and dearest, so we can then support you if you're not able to say what you need.
Amy, it's been a fascinating conversation. I'm sure there's so much more we could have talked about, but unfortunately we are coming to the end of the show. I want to thank you very much for coming along and telling us not only about Sue Ryder, but about hospice care in general. And I'm pretty sure it'll be a topic we'll visit again. Thank you so much. Okay, everybody, thank you for listening today. Jazakallah khair. Assalamu alaikum wa rahmatullahi wa barakatuhu.